Welcome back, everyone. Today, we're diving into a highly detailed explainer covering the complete clinical pathway of craniosynostosis. We are literally going step by step here, from that very first diagnostic observation all the way through to some pretty complex genetic categorizations. So if you're looking to perfectly cement this entire continuum without skipping a single crucial detail, you are in exactly the right place. Grab your notes and let's get started.
Here is our roadmap for today's explainer. We'll cover initial diagnostic steps, advanced imaging, non-surgical treatments, surgical interventions, multiple synostoses, and finally, specific craniofacial dysmorphic syndromes.
All right, Section 1, Initial Diagnostic Evaluation Steps. Let's look at where it all begins.
So the diagnostic order of operations always starts with a physical exam. Hands down, this is the most important diagnostic aspect. Now, if the exam is equivocal, we move to Step 2, which is a skull X-ray. During this time, you want to prevent the infant from laying on the affected side for several weeks. If there's still no improvement, we proceed to Step 3, a bone scan. And just a quick heads up here, refractory positional flattening can actually take up to 2 full years to correct.
Now here's a number you really need to lock in, 70%. When you're hunting for diagnostic clues on that skull X-ray, the classic radiographic sign of a sclerotic margin along one edge of the lambdoid suture, yeah, that shows up in about 70% of cases.
Moving right along, we encounter what's known as the beaten copper cranium, or BCC. It's exactly what it sounds like. You get this characteristic mottled appearance on the bone, featuring these round, poorly margined edges and lucencies of varying depth. But why does it actually happen? Well, it's caused by physical indentations in the bone from the underlying gyri of the brain, literally pressing outward against the skull. So what does this tell us about intracranial pressure, or ICP? You have to be careful here, because you cannot just assume all BCC means there's a global pressure issue. A local beaten copper appearance might simply be due to locally increased ICP. The absolute key takeaway is that BCC only correlates with generalized increased ICP when it is seen alongside 2 other specific findings: cellular erosion and sutural diastases. You really need the whole triad to confirm generalized increased pressure.
Okay, Section 2. Advanced imaging scans. Let's look a little deeper.
When you check the bone windows on a CT scan, some very specific markers pop up. For instance, an eroded or thinned intertable in the occipital region happens in about 15 to 20% of cases. And what's brilliant about this finding is how targeted it is. Greater than 95% of these thinned areas show up on the exact site of involvement. Plus, you might also notice that the suture appears closed. Now, flip that CT over to brain windows, and you get a completely different picture. Parenchymal abnormalities, meaning issues inside the actual brain tissue, are incredibly rare, occurring in less than 2% of cases. When they do happen, we're talking about things like heterotopias, hydrocephalus, or agenesis of the corpus callosum. On the flip side, significant expansion of the frontal subarachnoid space is super common. We see that in about 70% of cases, and by the way, you can also see that expansion in the synostosis of other sutures.
If you opt for a bone scan instead, you have to follow a very specific chronological timeline for isotope uptake in the lambdoid suture. In the first weeks of life, there's just usual inactivity, so don't let a negative scan early on fool you. The critical window hits at exactly 3 months of age. That's when isotope uptake actually peaks. And then throughout the rest of that first year, an overall increased uptake is typically what confirms craniosynostosis.
Section 3. Non-surgical treatment options. Let's talk conservative management. The great news here is that the majority of cases will remain static or even improve over time with simple non-surgical intervention. The magic number to remember is 85%. That is the massive success rate of simple repositioning. Just by placing the infant on their unaffected side or on their abdomen for a period of 3 to 6 months, you can usually observe resolution. But as with everything in medicine, there are nuances and exceptions. For example, if an infant has occipital flattening resulting from torticollis, simple repositioning isn't going to cut it. They are going to need aggressive physical therapy. And for more severe involvement, well, they might get a trial of molding helmets, although it is absolutely vital to note that no controlled study has definitively proven their efficacy. Finally, we have to acknowledge that despite our best non-surgical efforts, roughly 15% of patients will continue to develop a significant cosmetic deformity.
Section 4. Surgical interventions and risks. Moving into the OR.
When it comes to surgical intervention, timing is absolutely everything.
If the patient is 12 weeks of age or younger and they don't have severe disfigurement, a linear craniectomy is often perfectly adequate. However, the universally accepted ideal sweet spot for surgery falls between 6 and 18 months. The trade-off you really have to understand here is that while earlier surgery allows for less invasive procedures, once you pass that 6-month mark, more radical surgery might become necessary to actually achieve those good long-term outcomes.
All right, let's step right into the operating room. Step 1. The patient is positioned prone on a very well-padded cerebellar headrest. Step 2 is a fascinating yet crucial detail. The patient's face must be lifted and gently massaged every 30 minutes by the anesthesiologist. This is strictly done to prevent pressure injuries during what can be a long procedure. And Step 3, the actual surgical intervention, ranges anywhere from a simple unilateral craniectomy all the way up to an elaborate, full-team craniofacial reconstruction.
Let's zoom in on that linear craniectomy for a second. Anatomically speaking, this cut extends directly from the sagittal suture straight down to the asterion. Now, the absolute danger zone here is near the asterion because you are right in the region of the transverse sinus. Great care has to be taken to avoid a dural laceration there. Once that fused suture is safely excised, you can physically inspect it, and it characteristically demonstrates this distinct internal ridge.
Now we have to talk about blood loss, because infants have incredibly small blood volumes. Even in a perfectly executed, totally uncomplicated case, the average blood loss is between 100 and 200 milliliters. To put that into perspective for a tiny infant, that's significant, which means a blood transfusion is very often required.
Section 5. Multiple synostoses and FGR genes. Let's look at the genetics. So, what happens when multiple sutures fuse? This causes oxycephaly, which presents as a tower skull, undeveloped sinuses, shallow orbits, and elevated ICP. This process is largely driven by autosomal dominant mutations in the FGRR, or fibroblast growth factor receptor, genes. You definitely need to know the classic syndromes associated with this: Apert, Cruzon, and Pfeiffer. But do not overlook the newer recognized entities either, which include Baer-Stevenson, Munch, and Jackson-Weiss syndromes.
Section 6. Specific craniofacial dysmorphic syndromes. Let's compare them directly.
We're going to intricately compare a few of these, starting with Cruzon versus Apert syndromes. While they share the same base craniofacial findings, the differences are pretty stark. In Cruzon syndrome, 25% of cases are sporadic, and interestingly, hydrocephalus is rare. Contrast that directly with Apert syndrome, where a massive 95% of cases are sporadic, and hydrocephalus is incredibly common. Crucially, Apert also adds severe limb abnormalities to the mix, specifically syndactyly, or webbing of digits 2, 3, and 4, right alongside shortened upper extremities.
Synthesizing all this into our table here, we can see that Cruzon and Apert share those craniofacial findings of coronal and basal suture craniosynostosis, maxillary hypoplasia, shallow orbits, and proptosis. But take a look at the bottom row, Kleeblatt-Schädel. This condition is fascinating because it exhibits a completely unique craniofacial finding, a trilobular skull. Furthermore, it can occur completely isolated, or it can be associated with Apert's or thanatophoric dwarfism.
We have covered a ton of ground today, tracing every detail from that very first physical exam all the way to the specific digits affected in Apert syndrome. So I want to leave you with a provocative thought to chew on. With over 50 craniofacial dysmorphic syndromes currently described, how will our rapidly evolving understanding of FGFR genetics continue to reshape early diagnosis and these highly critical surgical timelines in the future? It's a huge question for the future of genetic medicine. Think about it. Thanks for joining this explainer, and as always, keep learning.